in approaching the problem?
Whether it is acute or a chronic problem or intermittent problem.
Exactly. The onset as such, is it acute or chronic? Okay, only two things. The onset acute, one group of problems you will consider all the time. If it is chronic, then it becomes, is it progressive, non-progressive, and under acute you will have an intermittent also. The differential diagnosis I need not tell you. Acute cerebellar problem, just few common things I want. I don't want all the list.
The common ones are acute post varicella cerebellitis and drug ingestion.
So para-infectious cerebellitis, either it is along with the infection or after the infection, we get demyelinating cerebellitis. That is the very common thing we come across. All right. Then?
And acutely after drug toxicity, phenytoin toxicity.
Excellent. Not only phenytoin, what are the other drugs, common drugs that will produce cerebellar problem?
Carbamazepine or
Carbamazepine. Carbamazepine. Anti-epileptic drug, these two are notorious, and eptoin, of course, is very notorious. So these two, then?
And some brain tumors, when they present with a bleed
Excellent.
or a hydrocephalus.
Excellent. Then?
Or sometimes brainstem encephalitis can present with.
Very good. In a brainstem encephalitis, you will have features of fever and associated cranial nerve involvements. Then?
Basilar migraine.
Common. What other things?
And other forms of intermittent ataxia can present acutely.
Common. One more thing I want you to remember. What is it?
Hydrocephalus. Vestibulitis.
Vascular. Vascular. It can be a hemorrhage or infarct. After neuroimaging has come into common use, we recognize acute cerebellar ataxia most of the time is associated with vascular problem, especially either a hemorrhage or infarct. So in acute, these five we need to remember. Of course, intermittent, I am not going to talk in future. Any book will give you all metabolic disorders are mainly intermittent. Ultimately, they become chronic progressive cerebellar ataxia. Coming to slow onset chronic cerebellar ataxia.
In chronic ataxia, it can be divided with ICP or without ICP. And with ICP, brain tumors are the first diagnosis. And without ICP, it can be hereditary ataxias.
I would prefer it to be progressive and non-progressive.
Yes.
Okay? Progressive and under progressive, some of them with ICT and some of them without ICT. So we will take progressive cerebellar ataxia. Okay? Once you have confirmed the fact that it is a progressive, immediately you have to think, is it associated with ICT feature or is it not associated with ICT features? If it is associated with ICT features, close your eyes, think about any space occupying lesions. What are the common space occupying lesions we come across within the cerebellum? Tell me.
Cerebellar astrocytomas.
Okay, neoplasm. I am putting everything in one diagnosis, neoplasm. After that?
Any bleed in cerebellar bleed.
Common.
Abscess.
Abscess. Then? Neurocystic sarcosis, tuberculoma. Often we come across, people will be presenting with cerebellar signs, you go and take imaging, it either shows a neurocystic sarcosis or a tuberculoma. They are also space occupying lesion. So neoplasms, abscess, infectious etiology, and one more last thing. Post-traumatic hematomas. Never forget post-traumatic hematomas. I came across as a PG, subdural hematoma, infratentorial. It is very rare. Child fell down some time back. So can present with hematomas, infratentorial, can present with progressive ataxia with ICT features. Once you are clear it is a progressive with ICT, without ICT. Without ICT, what are they?
Without ICT, they are mainly hereditary ataxias.
All the neurodegenerative disorders. Keep that like that in your mind. All neurodegenerative disorder, one differential diagnosis. What else?
Other hereditary ataxias like
neurodegenerative, neurometabolic, hereditary, everything put together one group. Then
posterior fossa malformations.
Congenital anomalies. Congenital anomalies. See, if we classify too many things, we tend to forget. So let us remember it is on a neurodegenerative disorders. All of them are nothing but a neurometabolic disorder. Earlier we saw it is a neurodegenerative. Now we realize every neurodegenerative disorder is a neurometabolic disorder. So you just learn them all. And the other group is congenital anomalies. Under congenital anomalies, what are all the things we should remember?
CV junction anomalies like basilar impression and Chiari malformation, Dandy-Walker cyst. and
Okay,
cyst.
CV junction problems. All CV junction problems, the commonest being Arnold-Chiari,
Arnold-Chiari malformation, basilar
Dandy-Walker.
impression, Dandy-Walker.
basilar impression. Okay, and hypoplasia, aplasia of the cerebellum. I think the differential diagnosis stops there. And a neurometabolic or a neurodegenerative disorder or a genetic abnormalities, only couple of disorders are there. What are they?
They usually present with intermittent or remittent ataxia.
Neuro or inherited spinocerebellar disorders. Only few are very important. What are they?
Friedreich's ataxia,
Friedreich's,
A-beta
A-beta
lipoproteinemia,
lipoproteinemia,
ataxia telangiectasia,
ataxia telangiectasia,
Refsum disease,
and spinocerebellar degeneration. Earlier, the spinocerebellar degeneration, we were classifying phenotype, all this olivopontocerebellar. Nowadays, we don't classify. All of them are genetically determined, gene-wise they are classified. Refer your books, they will give you. What you have to remember is spinocerebellar degenerations inherited, Friedreich's, ataxia telangiectasia,
A-beta lipoproteinemia,
all of them are autosomal recessive inheritance. There is, what are the autosomal dominant, X-linked dominant inheritance? Only one. What is it?
X-linked, they are adrenoleukodystrophies or
Adrenoleukodystrophy is the only inherited disorder that is X-linked. Bas. So you know everything about cerebellar problems, having understood it in this way. Okay. So what is your case now?
my case is a case of non-progressive.
So the minute you realize it is a non-progressive, is there any other non-progressive cerebellar features and the spastic features we can think of, not for this case, but for our discussion? Is there any other case you can think of? Please tell me. You don't.
I didn't get you.
Non-progressive cerebellar ataxia with spastic weakness. Is there any other clinical situation you can think of? What happened to following encephalitis and meningitis? Humpty number of times you will be having that case for examination at the 10th year or 9th year of age. But the history of damage to the brain would have happened at the 2nd year or a 1st year or a 3rd year. So for you, it becomes a non-progressive cerebellar ataxia with spastic weakness, secondary to a one-time damage to the brain. So that you have to remember. So post-encephalitic, post-meningitis, always a differential diagnosis for your cerebral perinatal anoxia. Is it okay?
Immunization, as madam told, ataxia telangiectasia, by the time you diagnose the child will be more than 2 years. How will you give pneumococcal vaccine? Yes, less than 2 years, everybody knows. The standard schedule follows. More than 2 years, what is the schedule? It will be either PCV 10 or 13, 2 doses at 8 weeks interval, followed 8 weeks later by PPSV, that is polysaccharide pneumococcal polysaccharide vaccine. So why polysaccharide vaccine is not given before 3 years?
Because it doesn't stimulate the T cell immunity, so there is no memory for the.
See, polysaccharide vaccines require IgM production for its immunity purpose, antibody response. So more than 2 years only your IgM level starts. That's the reason you give all polysaccharide, like say typhoid, pneumococcal, everything you give only after 2 years. But what they have done is they have conjugated this polysaccharide with a protein. So body will elicit IgG for protein, and that way it will also be providing protection to the polysaccharide. That's why you are using PCV, that is conjugated vaccine, before 2 years. But schedule is 2 doses at 8-week interval, followed 8 weeks later by PPSV 23. Because that gives a broader coverage. This gives effective protection. Okay.
How will you investigate your case?
To confirm the site of lesion and to find to get a etiological clue, I would do an MRI.
Neuroimaging plays a vital role in many of the situations. Without that, we cannot do. Okay? So neuroimaging will give you how far your cerebellum is affected or is there any other associated problems. All right. And one more practical point I really want you to remember. In a child who is suffering from a meningitis, you are treating the child. Okay? The cerebellar features were not there earlier. Now the child is all of a sudden developing cerebellar features. What will you think of? You have been following the child, you started antibiotics, child was doing great, everything. Now, the cerebellar features which was not present earlier, now it is coming into clinical picture. What is the reason? Come on, you know it, you know it. Excellent. Okay, hydrocephalus, how is it producing your cerebellar problem? Yes, hydrocephalus, associated complications of your meningitis, hydrocephalus is responsible. How? Fourth ventricle, when it gets dilated, what happens? Your cerebellum gets disturbed. Okay? I have about 6 or 7 slides just to summarize the clinical pictures. I'll just rush through them.
Thank you, ma'am.
This is just, I put everything in a nutshell so that for a PG it would be very useful. And dyssynergia, like all of us learn and study, but still we kind of get confused. Remember, when multiple group of muscles are functioning, they have to be, the function should be organized and coordinated. It is something like an orchestra. When that orchestrating is not happening, you get jerky, erratic, awkward movements. That is dysgynesia. And finger nose test and heel knee test, just imagine more than one joint is involved in this test. Okay? When more than one joint meant for each joint, agonist and antagonist. Okay? Multiple groups. Next comes the dysmetria. Remember, the ability to judge the speed, distance and direction of a movement. That is done by your cerebellum. When that fails, when cerebellum fails, then that fails. How do I recognize that? That by doing again finger nose test and heel knee test, where either I overshoot or undershoot. Okay? The next one is the coordination between agonist and antagonist. What happens in dyssteatokinesis? The repeated rapid movements are repeated alternating movements where the agonist and antagonist, when agonist is walking, antagonist must relax and vice versa. That fails. A rebound phenomenon also, the same issue comes in. When there is a rapidly, have to reverse the action. Okay. So tremor, intention tremor, posture tremor, rubral tremor, that you know. Hypotonia, I asked you, it is absence of cerebellar facilitation to the motor cortex. Pendular knee jerk, when you strike, it goes back and forth because of hypotonia. Dysarthria, you know, nystagmus, horizontal nystagmus. Gait, you have to remember, it is a staggering gait. Head tilt is a part of cerebellar problem. Titubation, again, you see in, but it does not have any localizing value. And this spiral, when you make the children do that in a cerebellum, it is scattered and large and irregular, cerebellar nystagmus. And this picture I request you to remember so that localization is easy. In anterior cerebellum, what you see is lower limbs, only the ataxia of the lower limbs. The trunk, the midline, vermis is mainly the trunk is represented. And the cerebellar hemispheres, the limbs are represented. So cerebellar hemispheres, appendicular ataxia, vermis lesion, truncal ataxia, anterior lobe problem, you will get a gait ataxia. Thank you.
It's a good presentation.
To Dr. Tilothamal. I now request Dr. Tilothamal to please present the gift of appreciation to Dr. Srividya. I request Dr. N. Uday Kumar to please give memento to Dr. Tilothamal. Is now here to hand over the memento to Dr.
Congratulations and all appraisal to the organizers of RIPE, which has RIPE to this stage. It used to be only in a small mini hall, and now it has come to the auditorium status. And I just enjoyed the just finished discussion, which is superb. Now, what we have planned now, instead of torturing a one candidate, I thought it will be nice if I make everyone alert just before the hypoglycemic stage. And I thought I will discuss with you the most common. How many are going straight away for examination? Raise your hand. Whether it is MD or DNB. How many are going for exam going students? Tell me. All of you. Sure? None is raising their hand. I am not going to ask you a question, don't worry. Be free. Sure? Huh? Don't worry. Yes. The idea is I learn from you and you learn from me. The best teacher is our own patients. So I thought we will quote some of our patients as 5 common causes for neonatal cholestasis and 5 most common clinical presentations during the exam. If you are thorough, I think you can manage these cases within the short period of 45 minutes or 40 minutes. Right. Dr. Kushbu is known to me. I have not trained her now for this presentation. She is going to talk probably extempo. You want to go through or I will go through?
I'll go through, sir.
You want to go through? Fine, yes.
This is a 64-day-old baby, which is jaundice noticed from day 3 of life. Diaper staining the urine, persistently pale stools from birth, not sick looking. Birth weight of this baby was 2.9 kg. There was no weight gain despite adequate feeding. No abnormal faces, dysmorphism or cataract noticed. Liver was 5 cm below the right costal margin. Firm spleen of 1 cm palpable. Cardiovascular system was normal. What next for the clinical diagnosis?
Yeah? I am supposed to ask you, you yourself have read. Come on.
Since this baby is born with a normal birth weight.
What is the gist here?
64 days.
What is the dominant symptom for which this child has come?
Jaundice noticed from day 3 of life with pale stool and diaper staining the urine from day 3 of life.
So the child is symptomatic for nearly 2 months from third day of life. That's one message that you can condense it. Agreed? The second one, of course, is the child has got yellow urine and has got pale stools from birth. Quite surprising. What is that you want to ask now? Next, in the clinical.
I would like to ask the meconium history in this baby.
Okay. I will not ask you. I always say, the best way to learn is 1 plus 1 is 2. Everybody knows. If you do not know, you learn from others. But nobody teaches 1 plus 1 is 3. Agreed? So you should not do certain things. That's what my approach. Then you learn a lot. Right. Now here, what are the things that you are ruling out? Then it will be easy for you to have a differential diagnosis 1 or 2. Now you tell me. What are the things you are ruling out in this child?
Normal birth
What
weight.
is unlikely, you tell me. Everybody will ask you what is the likely diagnosis. My approach is what is unlikely here.
Hepatitis is unlikely in this baby.
You think neonatal hepatitis is unlikely,
Yes, sir.
right? Most important, what I thought was right from beginning, the child is symptomatic from birth, right?
Yes, sir.
And it is already 64 days. So it's not a late onset jaundice. That is unlikely. So the differential diagnosis will not come there. So you will not think of rare conditions. Second, what else? The child has no abnormal faces or dysmorphia. You are supposed to tell us.
Does not have any
Why
abnormal.
I just say, if I ask her and if she takes time and if you take time, I may not be able to finish all the 5 cases. Because Srinivasan is already restless. It has crossed the time. So I will wait for 1 second, then I will go ahead so that we will finish more cases. You learn a lot. So next thing, what is that? No abnormal faces, no dysraphism or cataract. I'm happy if you are audible to yourself. Okay, don't worry. We are ruling out certain intrahepatic ductal dysplasias, like alagely. We are ruling out. Agreed? Cretinism. Yes, we are ruling out. Then
Intrauterine infections we are ruling out.
Downs, we are ruling out. Zellweger, we are ruling out. So many other congenital malformations may be associated. What you see from the face, you make a diagnosis of underlying condition. We are ruling out now, right?
Yes,
Then,
sir.
this is after all that 64 days old infant. But it has got a firm liver, big liver. We have to think some conditions in the very, very young infant with a large liver. One of the common conditions where you get a large firm liver is obstruction.
Obstructive.
Remember. Apart from abscess and so many things which you remember. So these are certain things which you are now ruling out on one side, thinking in your side. The child's birth weight is 2.9. And in spite of taking food, the child is not gaining weight. That's another feature here. So something is not either absorbed or something is lost from the body. So if this particular child has got a persistent pale stool, high colored urine, obviously must be having some form of a malabsorption. Agreed? There is no significant loss. So what question that you are going to ask right now in this, if you are going for an exam? I purposely omitted 1 or 2.
Feeding history.
You need to know the meconium history. That's where it starts. Right from birth it has got pale stool. So the meconium. So that history has to be told. Right? Now, what is the likely diagnosis right now? I have shown you the picture. It's a 64-day-old infant. Can I have the pointer?
Since,
Pointer is there?
since the baby has presented with jaundice from day 3 of life with pale stool and high colored urine, and we are thinking of obstructive jaundice, most likely diagnosis in this case would be biliary atresia.
So there are 4 babies of this type. You have got some pigment there. Agree? If you ask mother, she will say yellow, white, pale yellow. So many things will come to confuse you in the exam hall. Right? What do you see there? Doubtful. What do you see there? Undoubtful. Right? So when you examine the stool, always better you ask her, is it always like that or intermittently? That gives you some diagnosis. Even a tinge of pigment will rule out biliary atresia, as it for exam's sake. Right? That's what is you need to know. It is more or less a well-fed child. But the child is not gaining weight in spite of taking food. Something is more absorbed. What is that it can produce that? Maximum. The fat may not be absorbed because it has got a pale stool. The bile is not coming out. The bile is very important for digestion of the fat. So remember these things as you take history. The meconium history is very important in this child. That's what we are expecting this child. Possibility?
Biliary atresia.
Biliary atresia? This is not the usual. Usually biliary atresia starts anywhere between 10th day to 20th day of life. By that time you finish off the physiological jaundice business. So you have to follow these children who have had received treatment for the physiological jaundice and then go ahead and examining. That's what is the most critical period is 10 days to 20 days or up to 3 weeks. That's what is more important here. Right. But this particular child is symptomatic right from birth or 3rd day of life. This is called embryonic type or early onset type of biliary atresia. So what will you look for in these people if the child has got embryonic? But in what way this onset is different from conventional or traditional onset of biliary atresia?
Associated with other anomalies.
Excellent. Because it has got a fetal origin, late pregnancy probably, gestation period onset, you should look for congenital anomalies. The congenital anomalies are very commonly seen only in maximum group of early onset biliary atresia. That you remember, you should look for. If you answer that, nobody will bother you what are the congenital abnormalities because you are not writing theory. We will confine only to practical. Right? Agreed. So what next? What are you going to do next? You have tentatively taken a history, you have made a history diagnosis. History diagnosis alone, history evaluation of the symptoms will give you 75 marks in the exam. Then
Investigations.
you want to investigate. Are there anything else that you would like to gather information, right? The child has got a big liver, child has started losing weight, child has got a firm liver. You would like to get the history regarding any clinical history suggests you cirrhosis in this child. Because the onset was inside. So you should get a history regarding cirrhosis. What history will give you whether the child has got clinical cirrhosis or not?
Any bleeding tendency.
The most inevitable complication of biliary atresia is portal hypertension. That portal hypertension will present as massive upper GI bleed or tarry stool or upper abdominal distension on either side, pallor, like that you will have. That's what is more important in this child. Progressive abdominal distension suggests ascites. When there is portal hypertension in chronic liver disease, you will have ascites. Otherwise, in chronic liver disease, for practical purposes, you will not think of ascites. Portal hypertension is a must for ascites in cirrhosis. Agreed?
Yes, sir.
Right. What else? At any time whether there is any altered sensorium. That's a very important thing. But in pediatric practice, coming with an encephalopathy is a rarity. That's only in end stage. This child has come now only to the quarterfinal. It has to go through semi-final and then final stage of that. So, what is that you can expect in these people? You can expect what is called MHE, minimal hepatic encephalopathy. Minimal hepatic encephalopathy can present as dullness, less activity. Little older children may have confusion, incoherent speech, or slowness in everything, and writing, school performance, everything can be affected. Then you suspect personality changes, behavioral changes will crop up in these people. Then you call it as minimal hepatic encephalopathy, which is the most common presentation complication of a chronic liver disease. Remember that. And you can do diagnosis only by psychometry tests, and no other investigation will give you. Your ammonia may be little borderline in these people. So you have to prevent that by giving long-term certain ammonia reducers or precipitants you may have to avoid. That's what is we need next in the clinical. Right. You have made a clinical diagnosis of biliary atresia in view of persistent pale stool, diaper staining from beginning, and the child has got a firm liver, large liver, and poor weight gain in spite of taking feeds. What is it that you can do next? You can go ahead for ultrasound abdomen. You can't simply say tick mark ultrasound abdomen, which is wrong. You must specifically ask what you really want, which portion. So, you need to go in for milk-free ultrasound abdomen. You can give 5 milligram of phenobarbital for about 3 to 5 days to induce the enzymes. Urine routine including bile salt, bile pigment, liver function test, etc. What enzymes are more important in neonatal cholestasis when you really want to get some useful information? You are given AST, ALT, SAP, GGTP. Which one is more important? PT, PTTA. Select 2 of the 5. Immediate.
SAP is important.
Huh?
SAP.
LGBT?
SGPT.
We are talking about this case. SGPT? I never mentioned SGPT there. There's only ALT.
ALT and prothrombin time will be important.
Right. That is not important here. You have made a diagnosis of biliary atresia. Then why do you want? It is only for neonatal hepatitis. Orientate yourself. That's very important. So when you suspect biliary atresia, there is cholestatic jaundice. Cholestatic jaundice, the cholestatic enzymes will go up. Agreed? So you should think of only SAP and GGTP are the most important enzymes, and you will not bypass this, but that may not be of diagnostic feature here. PT-PTTA is not going to be very much affected in these people. So remember only 2 enzymes in biliary atresia. If the examiner asks you, surprisingly, you immediately say, sir, cholestatic enzymes, one word. Agreed? How much to learn? 5 are available, but you have to choose the one. It's not the battery of tests and select what is going wrong. That practice should go away from you. Be specific. Right. Then what do you expect in this patient? Do you expect
SAP will be elevated.
SGPT?
SAP,
SAP and
GGTP both will be elevated.
both will be abnormally high. Then that tallies with your clinical diagnosis. You are right in asking for this test. Right. Now what is there in this child right now? Let us see. The total bilirubin is 10, out of which the conjugate is 6.8. ALT, AST is not going to help you here. They are at 3-fold, 4-fold and 2-fold, 3-fold here. Albumin is not going to be much affected, and ALP, alkaline phosphatase, in 4 figures. And GGTP is also very, very high. Prothrombin time is abnormal, not very much grossly disturbed. Right? What does the ultrasound say in this child? What do you look for in ultrasound? You look for a rudimentary or a contracted gallbladder or absent gallbladder. Contracted gallbladder, for practical purposes, you should send the child on empty stomach. It may give you some information. Triangular cord, same. May not be picked up by many ultrasoundologists, only very few people. That only tells you there is in the hilar fibrosis of the entire biliary tract. Right. Then no intrahepatic biliary ductal dilatation or cyst. And what is your diagnosis? What next? What do you expect?
Probable diagnosis is extrahepatic biliary atresia.
Next you go for, your diagnosis you already made, that you have what? The biliary atresia is more or less with one investigation on imaging and one investigation on the cholestatic enzyme, you are now nearing the perfect diagnosis. Agreed? Now, what's next you are going to do? You have to confirm. What are the ways of confirmation? You can do a liver biopsy, then
Peroperative cholangiogram can be
you
done.
can do a peroperative cholangiogram. What about HIDA scan here?
HIDA scan also can be done.
It can be done. That should not be the answer. Just because it is available? No. Why? The child has already 64 days jaundice, persistent pale stool. Do you expect the HIDA isotope to come into the motion? It will never come. There is total block. You have made a clinical diagnosis. Why do you want another test to support that? After you saw continuously persistent pale stool, HIDA scan is out. You should not ask for it. Be specific. It can be done, should not be the answer. Never give the chance to the examiner to suspect you. You must be stubborn, strong. So when there is a persistent pale stool, the isotope will not come. You will not ask. Already the serum bili is more than 10. So how do you expect the uptake and then excretion here? It will not. So you will not ask for the test. It is invalid. So bypass that and then go for a liver biopsy. Right? The sensitivity, specificity of liver biopsy is anywhere from 90% to 95% with clinical correlation. So you will ask for it because it is only a semi-invasive test, but the prothrombin time, everything is fairly normal. The child is fit for liver biopsy. You will go ahead with liver biopsy. What do you expect in liver biopsy?
Bile ductular proliferation will be there.
You expect ductular proliferation because newer ducts have to improve, originate and carry the bile. Fibrosis because the child has got already firm liver. Widening of the portal tract and early cirrhosis may be expected in these people, though there is no clinical evidence. Biliary atresia because of pale stool, not a sick child, ultrasound features and biopsy. Fair enough for your confirmation. What are you going to do next?
Take up for the surgery, Kasai surgery for the child.
The next thing is hand it over to the surgeon.
Surgeons.
It's not no longer your case. Right? So, confirmed by laparotomy, perioperative cholangiogram, Kasai photoenterostomy, and the child improved. That's the usual routine. What we learn from this child? What do we learn? Moral, learning point. Hello. Sir, don't disturb me, but don't disturb me. Right. What do we learn here?
Early diagnosis of the condition and early referral for the surgery.
We are all now have got some clarity in making a diagnosis of biliary atresia. Persistent pale stool, well-thriving child, firm large liver. These are the clinical triad with a normal birth weight. That should be the minimum clinical criteria for diagnosis. So the clinical criteria for biliary atresia is normal birth weight, otherwise well-thriving child, though there may not be very good weight gain, persistent pale stool right from beginning, usual onset 10 to 20 days. You can get like this early onset as an embryonic type, no dysmorphism, and firm large liver. Enough? You have made a clinical diagnosis, you will carry this information to the exam hall and do it better. Right. Now, the second case. Baby referred at 3 weeks, you can go through. Baby referred at 3 weeks of age with jaundice. Prolonged neonatal jaundice, conjugated bilirubin in this child. History of jaundice, high colored urine was positive, stained yellow, pale stools, conjugate bili is more than 2 milligrams or 20 milligrams of the total bili, elevated serum transaminases, elevated SAP and GGTP, and abnormal PT, PTTA and INR, and low albumin. What are the differential diagnoses here? It could be intrahepatic. You will think of neonatal hepatitis syndrome, or if there is going to be dysmorphism, a la jelly, if there is going to be itching predominant, PFIC, or history of total parental nutrition, TPN induced, or cerebrohepatic, renal, combination of three major systems, think of Zellweger, microsomal disorder, or infective origin like torch infection. Extrahepatic. Sometimes when you make a diagnosis of extrahepatic biliary atresia, the examiner may ask you what are the causes for extrahepatic biliary obstruction. As a differential diagnosis for neonatal cholestatic syndrome, or now the current term is prolonged cholestasis of infancy. Extrahepatic biliary atresia, choledochal cyst, inspissated bile syndrome, the choledocholithiasis, spontaneous perforation of bile duct at the junction of cystic duct and bile duct, or high small bowel intestinal obstruction. These are the differential diagnoses. Then sometimes you can have the bili of very, very high when there is hepatic injury with associated hemolytic process. This is a 90 days old infant. Jaundice noticed on day 9 of life. Pigmented stool, diaper stain plus. Weight of the child at birth was 2.3. Weight gain 30 gram per day. Antenatal period was normal. No family history. The child is not looking very sick. Icterus is there. All consecutive stools, pigmented. Liver 3 centimeters, soft. Spleen 2 centimeters. What the diagnosis? What are the relevant diagnostic tests?
90-day-old infant with jaundice noticed since 9th day of life with pigmented stool and low birth weight. It's not sick looking, and all consecutive stools are pigmented with hepatosplenomegaly. Probable diagnosis neonatal hepatitis. Either it can be idiopathic neonatal hepatitis or the possibility of PFIC should also be considered in this case.
So in the exam, it is better to wait to impress in a